All right, welcome to Optic Surgeon, the ophthalmology podcast. This deep dive is tailored just for you, whether you're an ophthal resident sharpening those clinical skills or a final year MBBS student really getting ready to connect the dots on the boards.
That's right.
Today, we are zeroing in on a sign you absolutely must recognize and understand: proptosis.
It's really an alarm bell. Proptosis is never the diagnosis itself,
Right.
but it's a clear signal that something's going on, either in or around the orbit, or maybe even systemically.
Okay.
So our goal today is really to give you the tools to unpack this signal. How it presents, what could be causing it, how you figure out the why, manage it, and crucially, what are those absolute can't-miss takeaways?
Perfect. So let's paint a picture. Imagine you're in clinic, patient comes in, and right away, one eye just looks, well, different. Visually, it seems to be pushing forward. The classic description you often hear is that sort of staring or frightened appearance.
That initial visual cue is so important, isn't it? And as you get closer, as you start your exam, you begin to confirm it. You might notice eyelid retraction, which makes the eye look even more prominent. Or maybe there's leg ophthalmos, where the eyelid doesn't quite close fully over the cornea.
And then comes the palpation part. You gently try to push the globe back into the orbit, the retropulsion test.
Right.
And you feel it. There's increased resistance compared to the other side.
Exactly. You feel that fullness, that kind of pushback. And then you pull out your trusty exophthalmometer.
Yeah.
Let's say you measure, 22 millimeters in that eye compared to a more normal 17 or 18 in the other.
Or maybe even 21 versus 18 or 22 versus 20.
Sure. Any significant asymmetry, generally we say more than 2 millimeters difference between the eyes. That confirms this isn't just how they look, it's true proptosis.
And just like that, you've got an immediate clinical puzzle on your hands. Is this an orbital mass pushing things forward? Could it be related to their thyroid? Or are we dealing with an infection that needs urgent attention, like orbital cellulitis? That bulging eye just raises a whole cascade of possibilities.
Precisely. So let's start with the fundamentals. What exactly is proptosis? As you said, it's the abnormal forward displacement or protrusion of the eyeball. We also call it exophthalmos. Those terms are often used interchangeably.
And its significance, this is key, right? It is the most common sign of orbital pathology.
Absolutely.
But remember, it's a sign, a finding. It's never the ultimate diagnosis itself. It's pointing you towards something else causing that increased volume or push.
It's quite remarkable, actually, how much the eye can protrude before, vision is significantly affected just by stretching the optic nerve.
Right.
That nerve is about 25 millimeters long within the orbit, give or take, with some natural slack. It allows for several millimeters of forward movement before things get critically tight at the back.
And how we measure it is also fundamental. Protrusion can be purely axial, meaning the eye is pushing straight forward.
Like straight out.
Which is common in things like thyroid eye disease, where the muscles enlarge pretty symmetrically, or it can be non-axial.
Displaced, yeah. Up, down, in, out.
Exactly. And that non-axial displacement is a huge clue that there's probably a mass or some process in a specific part of the orbit pushing the globe off-center.
And the standard tool, as you mentioned, is the Hertel exophthalmometer. It measures from the lateral orbital rim to the corneal apex. Average readings hover around 17 millimeters, maybe up to 21 in some people.
Okay.
But the absolute critical number is that difference between the eyes. More than 2 millimeters difference is definitely abnormal, confirms true proptosis.
And what if the rim itself is displaced, like from trauma?
Good point. Yeah, if the lateral rim isn't reliable, you might need a different instrument, like the Naglik thermometer, which uses different reference points.
And a quick bedside trick.
Oh yeah, just stand behind the seated patient, look down over their forehead, compare the position of their corneal apexes relative to their cheeks or lower lids. Gives you a pretty good visual check for asymmetry before you even measure.
Simple, effective.
And combining that with the retropulsion test you mentioned, that increased resistance, these initial steps are crucial. They help confirm you're dealing with actual proptosis, not something just looking like it.
Okay, so we know what it is, how to spot it, measure it. Now, for the real meat of this deep dive, why does it happen? What are the underlying causes and mechanisms?
This is where we start building that differential diagnosis. And structuring the causes really helps. The big one, the most common cause of either unilateral or bilateral proptosis in adults, is thyroid eye disease. TED.
Right, TED. It's an autoimmune condition. And the mechanism is fascinating, that autoimmune inflammation targets orbital tissues.
primarily causing enlargement of the extraocular muscles and also an increase in orbital fat and connective tissue, basically stuffing the orbit too full.
And here's a really high-yield point about those muscles in TED you mentioned earlier.
Yeah.
The inflammation typically targets the muscle bellies, right? But it spares the tendons where they attach to the globe.
Exactly. Seeing that pattern on imaging fat muscle bellies, thin tendons, is a very strong clue for TED. Helps differentiate it from, say, myositis or other inflammations that might affect the whole muscle, tendon included.
And TED is just packed with other signs beyond the proptosis itself. Lid retraction, the Dalrymple sign, incredibly common, like 90% of patients.
Yeah, around that. It really contributes to that staring look. Then there's lag of thalamus, which leads to exposure problems on the cornea, diplopia, double vision, because the muscles get stiff and restricted.
And increased intraocular pressure.
Yep, especially in upgaze. That's often because the inferior rectus muscle gets tight and restricts upward movement, kind of tethering the globe.
Is that where the mnemonic comes in? I'm slow.
That's the one.
Oh.
But the muscles typically involved, roughly in order of frequency, inferior rectus, medial rectus, superior rectus, lateral rectus, and sometimes the obliques get involved too.
I'm slow.
Okay. And while it's less common, thankfully occurring in maybe under 5% of cases, you must be vigilant for compressive optic neuropathy in TED. Absolutely critical. This happens when those enlarged muscles or the increased fat compresses the optic nerve back at the orbital apex. It's a true sight-threatening emergency within TED.
Got it. Okay, shifting gears. Orbital tumors and masses, another major category causing proptosis.
Right. And their presentation can vary wildly depending on the type. Think about rhabdomyosarcoma.
Crucial for kids.
Absolutely.
Yeah.
It causes rapidly progressive, often painful proptosis. It's the most common malignant primary orbital tumor in children. Sudden painful proptosis in a child, you have to think rhabdo or infection and act fast.
Okay. What about adults?
In adults, the most common primary orbital tumor is actually benign, the cavernous venous malformation, or CVM. Used to be called cavernous hemangioma.
Right.
These are typically slow-growing, painless. A classic feature, though not always present, is that the proptosis might worsen with the Valsalva maneuvers.
Like bending over, coughing, straining.
Exactly. Because it's basically a collection of low-flow venous channels that can engorge when venous pressure increases.
Interesting. What else?
Well, you have tumors directly involving the optic nerve, like optic nerve gliomas and meningiomas. These are often associated with gradual vision loss because of where they are. Meningiomas might show calcification on a CT scan, which is a helpful clue. Lymphoma can also present in the orbit, often looking more like a fleshy infiltration on imaging.
Okay. Then there are inflammatory conditions, which can be tricky mimics.
Very tricky. Nonspecific orbital inflammation, sometimes called orbital pseudotumor or idiopathic orbital inflammatory syndrome.
Lots of names.
Yeah. It can present with acute, often painful proptosis, restricted eye movements, redness, swelling. It can look very much like an infection.
But it's sterile inflammation.
Exactly. No bacteria involved.
And speaking of infection, orbital cellulitis, critically important.
Absolutely top of the list for emergencies. This is a bacterial infection posterior to the orbital septum, usually spreading from adjacent sinusitis, especially the ethmoid sinuses.
And this is the most common cause of proptosis in children overall, right? More common than rhabdo.
Yes, overall, orbital cellulitis is more common in kids. And this is a point you absolutely need locked down. Differentiating orbital cellulitis from the much milder preseptal cellulitis.
Preseptal is just infection of the eyelid tissues in front of the septum.
Correct. Orbital cellulitis means the infection has breached that septum and is inside the orbit itself, threatening the eye and potentially the brain.
So what are the key differentiating signs? How do you know it's orbital?
Okay, the red flags for orbital cellulitis are severe pain, often fever, painful ophthalmoplegia, meaning eye movements are limited and hurt significantly when the patient tries to move the eye.
Okay, painful movement.
Yes. Plus vision loss and potentially a relative afferent pupillary defect, or RAPD.
The RAPD, tested with the swinging flashlight.
That's the one. Shows the optic nerve isn't working properly. Preseptal cellulitis doesn't have these orbital signs. Vision is fine, eye movements are full and painless, though the lids might be swollen shut. No RAPD, no proptosis.
Huge difference in urgency and management.
Massive. Orbital cellulitis is a true ophthalmologic emergency needing IV antibiotics and usually imaging right away.
What other inflammatory things cause proptosis?
You can get posterior scleritis, inflammation of the back wall of the eye, which can spill over into the orbit. That can cause pain, decreased vision, sometimes optic nerve or macular edema. And systemic conditions like sarcoidosis or GPA, formerly Wegener's, can involve the orbit.
And in immunocompromised patients.
You have to worry about aggressive fungal infections like mucormycosis, especially if they have diabetic ketoacidosis. That's another major emergency.
Okay, how about vascular abnormalities?
Distinct group. A carotid cavernous fistula, or CCF, that's an abnormal connection between the carotid artery system and the cavernous sinus veins behind the eye.
High pressure to low pressure.
Exactly. That causes classic pulsal proptosis. You might actually feel or see the eye pulsing slightly, often with a very red chemotic eye, and you might hear a brute, a swishing sound, if you listen with a stethoscope over the eye or temple.
Wow. Pulsatile proptosis and a brute think CCF.
Definitely. Then there are orbital varices. These are like varicose veins in the orbit. Like the CVMs, they can cause intermittent proptosis that worsens with things that increase venous pressure, Valsalva. Putting the head down.
Got it. And don't forget trauma.
Never forget trauma. An orbital hemorrhage, a bleed behind the eye, or even a bad fracture displacing orbital contents can cause sudden, usually painful proptosis.
And that can be an emergency, too.
Yes, if it causes an orbital compartment syndrome pressure building up rapidly and compressing the optic nerve, needs urgent decompression.
Okay. Now, before we move to workup, we have to talk about pseudoproptosis.
Ah, yes, the great mimic.
Critically important because it looks like proptosis, but the orbital volume isn't actually increased. It's more of an optical illusion, right?
Exactly. And you need to rule out true proptosis before you label something as pseudoproptosis. Don't miss the real thing.
So what causes this apparent protrusion?
Key causes include high axial myopia. The eyeball itself is just anatomically longer, more nearsighted, so it naturally sits further forward.
Makes sense.
Or it could be contralateral anophthalmos. The other eye is actually sunken back or smaller, making the eye you're worried about look relatively prominent by comparison, even if it's in a perfectly normal spot.
Ah, the comparison trap.
Yeah. An asymmetric eyelid position is a big one. If one eyelid is retracted, like we see in TED, which causes true proptosis, but the retraction enhances the appearance.
Right.
Or if the other eyelid has significant mucosis, if it's droopy. Remember Herring's law of equal innervation.
If the brain sends extra signal to lift a droopy lid.
It sends the same extra signal to the other side, potentially causing the other upper lid to retract, making that eye look proptotic.
So you might need to lift the cryptotic lid manually or cover that eye to see if the contralateral lid retraction resolved.
Exactly. Good diagnostic maneuver. Also, if one eye is hypotropic, sitting lower than the other, the normally positioned eye can look relatively proptotic just because it appears higher and more forward. You have to be aware of these visual tricks.
So diagnosis and differential diagnosis really begin the moment you see the patient. You're piecing together all these clues. Is the onset rapid, like hours or days, or slow and insidious over months or years? Is it painful or painless? Unilateral or bilateral? Are there associated symptoms, fever, vision changes, double vision, pulsation?
Each piece of information helps you narrow down that broad list of possibilities we just ran through. Rapid and painful points one way, slow and painless points another.
And as we said, carefully differentiating true proptosis from pseudoproptosis using your exam exophthalmometry, checking globe-sized lid positions is fundamental, avoids unnecessary workup.
Absolutely.
Okay, so you've seen the patient, noted the proptosis, started forming your differential. How do you systematically work this up and then manage it? It starts, as always, with a thorough history.
Absolutely. You need the details. Onset, acute versus chronic. Progression, stable, worsening, fluctuating, any pain character, location. Vision changes, blur, double vision, color desaturation, fever, headache, pulsation, any noise in the head, like a brute.
And risk factors.
Right. History of trauma, recent sinus infection or dental work, known thyroid disease, family history of anything relevant, immunocompromise, smoking history, especially for TED.
Then the examination. This is your time to shine, gathering objective data.
Definitely. Start with inspection. Confirm laterality. Is it axial or non-axial displacement? Look closely at the eyelid's retraction. Log ophthalmos ptosis. Look for visible pulsations. Maybe listen for a brute with a stethoscope over the closed eyelid or temple.
Then measure.
Exophthalmometry. Use the Hertel or Noggle if needed. Measure in primary gaze. And, importantly, consider measuring with Valsalva if you suspect a vascular lesion, like a varix or CVM.
Check retropulsion.
Yep. Assess that resistance. Then test ocular motility, full eductions versions. Note any restriction or pain on movement. If there's restriction, you might consider force duction testing later to differentiate mechanical restriction, like a trapped muscle, from a nerve palsy.
Crucially, pupils. Check for RAPD, signals optic nerve dysfunction.
Essential. Assess visual function formally. Best corrected visual acuity. Color vision testing, often affected early in optic neuropathy, and confrontation visual fields. Maybe formal perimetry if you suspect nerve involvement.
Fundus exam, dilated.
Got to look at the back. Check the optic disc for swelling, hyperemia, or pallor. Look for choroidal folds, those subtle wrinkles, suggesting posterior globe compression.
Measure IOP.
Yes. In primary gaze and in upgaze, especially if you suspect TED due to that potential inferior rectus restriction.
Anything else? Palpation.
Yes, gently palpate the orbital rims and surrounding tissues. Feel for masses, tenderness, warmth, or crepitus, that crackling feeling suggesting air in the tissues, maybe from a fracture into a sinus.
Okay, comprehensive exam. What about tests? Imaging seems key.
Almost always necessary. CT is often the first choice in urgent situations. Suspected orbital cellulitis. CT will show sinus disease, any abscess, bone involvement. CT for fractures, hemorrhage. It's also quite good in TED for showing those enlarged extraocular muscles with tendon sparing. And it picks up calcification, like in some meningiomas.
But MRI?
MRI is generally superior for soft tissue detail. It's better at characterizing masses. Is it solid, cystic, fatty, vascular? It's great for delineating the extent of tumors or nonspecific inflammation. So often MRI is preferred if the situation isn't acutely emergent and you suspect a soft tissue process. Sometimes you need both.
Makes sense. Any labs?
Depends on the suspicion. Thyroid function tests, TSH, free T4, maybe antibodies, are essential if TED is on the list. Blood cultures or sinus aspirate cultures if you suspect cellulitis, maybe inflammatory markers like ESR or CRP for NSOI or systemic conditions. And if you find a distinct mass, a biopsy is often the ultimate diagnostic test.
And referral?
Definitely. Urgent ophthalmology evaluation is always warranted for new proptosis. Then, depending on the suspected cause, you'll likely need co-management. Endocrinology for TED, infectious disease for complex cellulitis, oncology or neurosurgery for tumors, rheumatology for systemic inflammatory stuff. DEEM approach, often.
Right. So, management, you've worked it up, you have a diagnosis or at least a strong suspicion. How do you treat it?
It's entirely cause-specific. There's no single treatment for proptosis itself. You treat the underlying condition.
Examples.
Orbital cellulitis needs prompt, often inpatient, broad-spectrum intravenous antibiotics. Active inflammatory thyroid eye disease might need systemic corticosteroids, sometimes orbital radiation, or newer biologics to quell the inflammation. Nonspecific orbital inflammation usually responds very well to systemic steroids too.
Tumors.
Often require surgical excision. Sometimes radiation or chemotherapy is needed, depending on the tumor type and location.
Acute hemorrhage or fracture causing nerve compression.
That might need urgent surgical decompression to relieve the pressure. Vascular lesions like CCFs or varices might need interventional radiology for embolization or sometimes surgery.
But regardless of the cause, if there's significant proptosis or lid retraction causing exposure.
Yes, ocular surface protection is absolutely paramount. You have to prevent exposure, keratopathy, corneal ulcers, potential vision loss.
What does that involve?
Start simple. Frequent, preservative-free artificial tears, lubricating ointments, especially at night. If that's not enough, consider taping the eyelids shut at night, using moisture shields or goggles.
More severe cases.
May need a temporary or even permanent tarsorrhaphy, which is partially sewing the eyelids together to narrow the opening and protect the cornea. Also need to manage elevated IOP if present, especially in TED with topical medications. And just briefly touching on the surgical sequence for severe TED once the inflammation is quiet.
Right, the staged approach.
Typically, it's orbital decompression first, if needed, to make more space and reduce proptosis or optic nerve compression. Then, if there's residual double vision, strabismus surgery on the muscles, and finally eyelid surgery to correct retraction or lagophthalmos, decompression, strabismus, eyelids.
Okay, we've covered a huge amount of ground. Let's try to synthesize this. What are the absolute highest yield pearls, the things you need readily accessible when you see that bulging eye?
Filtration is key. Think fast versus slow, painful versus painless. If you see rapid onset unilateral proptosis, especially if it's combined with pain, vision loss, painful ophthalmoplegia, or a RAPD stop, this is an emergency.
What's on that emergency list?
Top differentials: orbital cellulitis, possibly rhabdomyosarcoma in a child, or acute orbital hemorrhage. This demands urgent action imaging, usually CT first, probably IV antibodies immediately if infection is suspected, or surgical consultation.
Okay, contrast that with?
Contrast that with bilateral proptosis, or proptosis that's been slowly developing over months or years, may be painless. That pattern often points towards TED. or perhaps a slowly growing benign tumor like a CVM. Less immediately emergent, but still needs thorough workup.
Reemphasize the orbital versus perceptal cellulitis distinction.
Absolutely critical. Orbital has the proptosis, the painful restricted movements, vision loss, plus RAPD infection behind the septum. Perceptal is just lid swelling redness in front of the septum with normal vision and motility. Orbital needs 5E antibiotics and imaging urgently. Perceptal usually managed with oral antibiotics as an outpatient unless severe.
Key signs that just scream TED.
The sheer frequency of lid retraction, Dell-Rimpel sign 90%, von Graef sign, lid lag on downgaze, Gold-Zeiher sign, that injection over the horizontal rectus insertions, increased IOP and upgaze, and that I'm slow muscle involvement pattern, but always rule out compressive optic neuropathy in TED.
Okay. X-ophthalmometry.
It's your objective measure. 2 millimeters difference between the eyes confirms true proptosis, non-axial displacement. Think about where a mass might be pushing the globe off-center. Example, superior mass pushes eye down.
And the red flags again?
Red flags demanding urgent attention and imaging, CT or MRI. RAPD, optic disc swelling or pallor, painful limitation of motility, significant or rapidly progressive vision loss. Don't sit on those.
So the final takeaway message.
Proptosis is a critical sign. It's that alarm bell, signaling something is wrong in the orbit or systemically. It demands a systematic, rapid, and thorough evaluation. Your ability to recognize it, differentiate true from pseudo, navigate the differential based on clues and imaging, it's crucial for protecting vision and finding the underlying cause.
Don't just note the bulging eye. Figure out why it's bulging.
Exactly. Let it guide your investigation.
That's a wrap. Stay focused. Keep learning. Subscribe.